Hello, my friends. I'm Dr. Julia Parker, urologist and senior health specialist, and today we're going to have one of the most important and potentially life-saving conversations for anyone over 70, how to safely cut unnecessary pills. If your pill box looks like a second breakfast and your energy feels borrowed from tomorrow, this message is for you. Deprescribing is the careful, stepwise process of reducing or stopping medications that no longer serve your health goals. It isn't rebellion against modern medicine, it's mature medicine, aligning treatment with the realities of your body today. Over decades of practice, I've watched people regain balance, memory, and calm simply by removing the wrong drug at the right time and in the right way. Fewer pills, more life. That's our aim. Let's start with a truth we rarely say out loud. The medicine that protected you at 55 may be burdening you at 78. As we age, our liver and kidneys clear drugs more slowly. Our brain becomes more sensitive to sedatives. Our blood pressure can dip when we stand, and our daily priorities shift from chasing perfect numbers to preserving strength, clarity, and independence. Polypharmacy, taking 5 or more medicines, plus over-the-counter products and supplements, is common after 70, and each additional item raises the risk of interactions, dizziness, constipation, confusion, and falls. Yet nobody hands you a map for getting off the carousel. That map is what we'll build together now. The first step is to turn your medication list into a living story, not a static inventory. Spread everything out on a table: prescriptions, eye drops, inhalers, creams, vitamins, minerals, powders, and herbal blends. For each item, answer 4 questions in plain language. Why was this started? What dose do I take, and when? What benefit do I still feel or measure that matters to me? What side effects or hassles am I tolerating? Dry mouth, foggy mornings, swollen ankles, constipation, heartburn, restless sleep, dizziness when I stand, bathroom urgency at night. Anything that no longer has a clear why, a felt benefit, or a tolerable side effect profile gets a star. That star is not a stop sign. It's an invitation to talk. The second step is to name your goals. I ask every older adult 3 simple questions. What do you want more of? Energy, steadiness, memory, appetite, ease of movement? What do you want less of? Falls, naps that steal your afternoon, night awakenings, anxiety, ER visits? And what does a good week look like? 2 walks with a friend, cooking a meal, tending your garden, playing a board game, and remembering the rules. Your answers become the compass for every deprescribing decision. If a pill improves a lab number but costs you safe walking, it's failing your goals. If a supplement promises brain support but leaves you constipated and cranky, it isn't supporting your life. The third step is to rank medicines by risk in older adults. Some categories routinely cause trouble after 70. Sedatives and sleep aids, benzodiazepines like lorazepam and clonazepam, or the Z drugs like zolpidem can worsen balance, memory, and reaction time. Anticholinergics, medicines that dry the body, including some bladder drugs like oxybutynin, older antidepressants like amitriptyline used for sleep or nerve pain, and over-the-counter antihistamines like diphenhydramine can cloud thinking, strain the bowel, and slow the bladder. Daily NSAIDs like ibuprofen can irritate the stomach, raise blood pressure, and burden the kidneys, especially paired with blood thinners or certain heart medicines. Long-term, automatic use of proton pump inhibitors for heartburn can be more than you need if the original ulcer healed years ago. Stacked blood pressure medicines may drive your numbers perfect on paper, while your body tips when you stand. Complex diabetes regimens can risk low sugars that leave you shaky and confused. None of these are bad drugs. They're tools with sharper edges in later life. Knowing where the edges are lets you handle them with care. The fourth step is to choose one change at a time. Deprescribing is not a race. Your brain and body love gradual shifts. Start with the highest risk medicine for your goals, often a sedative, an anticholinergic, or a duplicate blood pressure pill. Create a written plan with your clinician or pharmacist. Exact dose changes, how many weeks you'll hold each step, which symptoms to watch for, what to do if those symptoms show up, and when you'll check in. A good taper respects biology. For benzodiazepines, that might mean cutting 10 to 25% of the dose every 2 to 4 weeks, slowing down at the smaller doses. For proton pump inhibitors, it may mean moving to every other day for a couple of weeks, then using an H2 blocker as needed while you change evening habits. For blood pressure regimens, it could be removing one agent and remeasuring seated and standing pressures at home, morning and late afternoon, for 2 weeks. Think like a pilot. Small adjustments, steady instruments, frequent checks. The fifth step is to pair every subtraction with a supportive addition. Stepping down a sleep pill. Build a sleep routine. Consistent wake time, morning light, limited caffeine afternoon, a quiet hour before bed, a cool, dark bedroom, and a short breathing practice. 4 slow breaths in, 6 slow breaths out, while sitting at the edge of the bed. Easing off daily, NSAIDs. Add heat in the morning and a 10-minute strength circuit for the muscles around your sore joint. Rebalancing blood pressure meds. Hydrate earlier in the day and rise from bed with a pause. Sit, flex ankles, stand. Simplifying a diabetes plan. Anchor your meals to a rhythm your body recognizes, and prioritize protein at breakfast for steadier mornings. Cutting back an anticholinergic bladder medicine. Shift fluids earlier. Avoid late evening irritants like coffee and alcohol. Practice timed voiding, and try a 5-minute daily pelvic floor routine. The point is simple. Deprescribing works best inside a lifestyle that supports your biology. Now let's walk through common categories, how to approach them, and what to expect. Start with sedatives. If you've relied on a benzodiazepine or a Z drug, I won't pretend that tapering is easy. The brain gets used to that chemical lullaby. But there is a way through. We reduce the dose slowly, stabilize at each step, and focus on daytime habits that raise natural sleep drive, light, movement, and regular meals. Expect that some nights will test you. On those nights, use your routine like guardrails, a warm shower, a paper book, a mindful breath sequence. Do not chase sleep with extra pills. Success here isn't perfect sleep. It's brighter mornings, stronger balance, and sharper memory. That's the prize I've seen again and again. Anticholinergics deserve vigilant attention. If you're taking an older bladder drug and you or your family notice fogginess, dry mouth, constipation, or new confusion, ask about alternatives with fewer cognitive effects and about behavioral strategies. If you use diphenhydramine as a PM sleep helper, recognize that its drying effect can worsen nighttime urination paradoxically by irritating the bladder and that it lingers in the brain. Trading it for a real sleep routine is often a turning point. If you're on amitriptyline for sleep or for nerve pain, ask whether low-dose alternatives or non-drug strategies could achieve the same relief without the mental haze. Proton pump inhibitors are invaluable for the right indications, but long, automatic use is common. If you began after an acute gastritis or a brief ulcer and kept going out of habit, a step down is reasonable. Plan for a few bumpy nights as stomach acid rebounds. Use an H2 blocker as a bridge. Raise the head of your bed, eat an earlier, lighter dinner, and keep a heartburn diary so you and your clinician can separate the temporary rebound from persistent reflux that truly needs treatment. Pay attention to the calendar. Most rebounds settle within 2 to 4 weeks if your evening routine supports your physiology. NSAIDs are another balancing act. If joint pain is a daily guest, it's tempting to take ibuprofen or naproxen every morning. But at 70 plus, daily NSAIDs can nudge blood pressure up, thin the protective lining of the stomach, and strain kidneys, especially if you're also taking a diuretic or an ACE inhibitor. A safer plan often looks like this. Schedule acetaminophen within safe daily limits. Use topical anti-inflammatory gel on the specific joint. Add a 5-minute strengthening and balance routine you can do while the kettle boils, and reserve oral NSAIDs for short flares with stomach protection if your clinician agrees. The real therapy for osteoarthritis is strength and movement. Pills are temporary assistance, not permanent staff. Hypertension therapy should serve your life, not your cuff alone. If you feel lightheaded when you stand, if you avoid stairs because your legs don't trust your brain, or if your pulse races after you rise, your regimen might be overambitious or poorly timed. Ask for orthostatic checks, blood pressure seated, then standing at 1 minute. Consider simplifying to 1 or 2 well-tolerated agents, spacing them thoughtfully, and accepting a slightly higher target that protects your brain and bones from falls. I'd rather see you walking confidently than winning a numbers contest that leaves you on the floor. Diabetes regimens deserve a gentler horizon in later life. If you've never had severe highs but you fear lows, revisit your targets. Nighttime hypoglycemia steals energy the next day and endangers your safety. We often reduce or stop sulfonylureas, adjust insulin timing and dose to prevent nocturnal dips, and simplify the meal plan to emphasize steady routines. The goal is stable, safe glucose that supports your clarity and strength, not a textbook perfect number that costs you peace. Cholesterol therapy is nuanced. If you've had a heart attack or a stroke, continuing a statin often remains beneficial. But if you've never had a cardiovascular event and your statin leaves you with muscle aches that make you stop walking, your most powerful heart medicine, then the trade-off may need revision. Ask your clinician about your absolute risk in the next 5 years, not a lifetime, and balance that against how you feel each day. Many older adults choose a lower dose, a different agent, or, in some cases, discontinuation for primary prevention when daily quality truly suffers. Aspirin for primary prevention, preventing a first heart attack or stroke, has fallen from favor in older adults because bleeding risks often outweigh benefits. If you're on aspirin without a history of heart attack, stroke, or certain vascular procedures, ask whether it's still warranted given your age and any history of stomach bleeding or easy bruising. If you're on a blood thinner for atrial fibrillation and also take aspirin, those two together can dramatically raise bleeding risk unless there's a specific reason to combine them. Bring this up, it matters. Opioids and gabapentinoids must be handled with care. For acute injuries or post-surgical pain, opioids have a role. For chronic non-cancer pain, they can sap energy, slow the bowel, and combined with sedatives, depress breathing, especially dangerous at night. A thoughtful taper aims at function. More minutes on your feet, longer walks, better sleep. We bring in physical therapy, pacing strategies, warmth, topical treatments, and mood support. We also protect the bowel proactively, fiber, fluids earlier in the day, and gentle movement, so the taper isn't sabotaged by constipation. Supplements deserve the same scrutiny as prescriptions. Natural does not mean low risk. High-dose vitamin D stacked with calcium can constipate and rarely raise calcium levels too high. Ginkgo combined with blood thinners can increase bleeding risk. Multiple multivitamins add up. Sleep herbal blends layered over sedatives create the same daytime grogginess you're trying to escape. Keep what serves a documented need and let go of duplicates and maybes. How do you track progress? With function, not just numbers. Use a small, friendly notebook. Each evening, jot down 3 ratings from 1 to 5: energy, steadiness, and clarity. Add 1 sentence about sleep quality and 1 about bowel comfort. Do the 30-second sit-to-stand test once a month. Arms crossed, stand up and sit down as many times as is comfortable. Over time, as sedatives shrink and blood pressure is right-sized, I often see the ratings rise and the stand count improve. That is deprescribing turning into daily life. Let me share brief snapshots that reflect patterns I've seen. A 79-year-old retired librarian on a nightly PM pain pill, a bladder anticholinergic, and a sleep aid feels foggy by noon and unsteady at dusk. We remove diphenhydramine first, coach a real sleep routine, shift fluids earlier, and add a warm shoulder wrap and stretches instead of the PM pill. 2 weeks later, her afternoons brighten. 1 month later, we taper the sleep aid by 25% every 2 weeks, holding steady when a rough patch hits. At 10 weeks, she tells me, I still wake once, but I don't feel drugged. I feel present. That's deprescribing. An 82-year-old widower on 3 blood pressure medicines and a nitrate started years ago complains of head rush on standing, so he avoids walks. We remove the nitrate, spread the remaining doses, and accept a slightly higher systolic target. He hydrates earlier, pauses before standing, and schedules a 10-minute morning loop around the block. 1 month later, the wooziness fades and his steps grow confident. His daughter says, he laughs more. That's deprescribing. A 76-year-old on daily ibuprofen plus a stomach protector for knee pain finds herself puffy, gassy, and tired. We build a focused plan. Acetaminophen on schedule within safe limits, topical gel directly on the knee, a 5-minute quadriceps strengthening routine, and NSAIDs reserved for flare days only. Her blood pressure eases, her stomach calms, and she goes back to climbing the front steps without gripping the rail. That's deprescribing. Now, how do you talk to your clinician in a way that sparks partnership rather than pushback? Try this sentence. My priorities are steadiness, clarity, and independence. Can we review my medications with the goal of reducing fall risk and simplifying where it's safe? Bring your starred list. Ask, if we change just one medicine this month for the biggest safety or energy gain, which would you choose and how would we taper? Ask for a written plan and a follow-up date. Invite your pharmacist into the conversation. Pharmacists are experts at spotting duplicate therapies and anticholinergic burden. If a clinician seems rushed, anchor the conversation with a single high-yield target. Then book a medication review visit dedicated to the rest. Caregivers, you are crucial allies. Help gather the full list, every bottle and packet. Observe subtle changes, fewer near falls in the kitchen, livelier conversation in the afternoon, 1 less nap, easier transitions from chair to standing. Protect the pace. Deprescribing fails when rushed. It succeeds when steady. Celebrate each held step in a taper as a win, not just the final dose. Let's talk about the emotional side. Some people fear that deprescribing equals abandonment. It's the opposite. It's a recommitment to what matters, waking up clear, walking safely, remembering your stories, enjoying your meals, sleeping with fewer interruptions, and staying out of the hospital. It's choosing the medicine list that belongs to the person you are now, not the person you were 10 or 20 years ago. It's medicine in service of your life, not the other way around. If you're wondering where to begin after this video, begin with 1-starred medicine. Book a conversation focused on that single item. Say, I'd like to taper this safely because my goals are steadier walking and clearer mornings. That one sentence changes the room. Then build your supports, your morning light, your hydration before noon, your 10-minute movement, your wind-down ritual, your bathroom nightlight, your 5 deep breaths. These are not decorations. They are the floor your nervous system stands on while we shuffle the deck of medicines. There will be bumps. On week 3 of a sleep aid taper, you might have 2 restless nights. That doesn't mean you can't do it. It means your brain is recalibrating. On week 2 of a PPI step-down, you might feel heartburn flare for a few evenings. That's rebound. It fades when your habits support your physiology. On day 4, without your usual midday ibuprofen, your knee might grumble. That's when the gel, the heat, and your strength routine do their job. Resisting the urge to backtrack at the first bump is the art of deprescribing. I'll close with a story that captures why this matters. A 77-year-old gardener came to me certain her best days were behind her. She took a nightly sedative, a bladder anticholinergic, and daily ibuprofen with a stomach pill. We treated her medicine list like her garden, pulling weeds one at a time, not yanking the soil bare. 8 weeks later, she told me, "I got dirt under my nails again." She could kneel, stand without pitching forward, and recall the names of her roses without searching. The medicine list was shorter, yes, but the deeper change was confidence. She trusted her legs, her memory, and her day. Here is the sentence I want you to remember. The right pills at the right time can save your life, but fewer, wiser pills after 70 can give your life back to you. If this message helped, share it with someone you love who is juggling a complicated pill box. If you have a story of simplifying your regimen and feeling more like yourself again, tell us in the comments. Your experience may be the encouragement someone else needs to begin. And if you want more practical, compassionate guidance for thriving in the years ahead, subscribe to this channel and stay close. We're building a community where informed, courageous patients lead the way. As always, this is educational. Do not change or stop any medication without a plan you create with your clinician. Bring your list. Bring your goals. Bring your courage. You deserve care that matches the life you want to live. I'm Dr. Julia Parker, and I'm cheering for your next lighter, clearer, steadier chapter.